the earlier you start HRT, the better. And that's what we teach in HRT University. Like, please don't wait for these ladies. HRT has no age. It should be utilized when medically necessary, whether the woman's 20 years old or 50 years old, or 70 or 80 or 90. I have patients that are in their 80s and 90s when I've started them on hormone replacement therapy, and they are all the better for it. What's going on, everybody? Nico Misleh here with the HRT University podcast. I know I'm using the name and title HRT University more now. I want it to be clear that, guys, this is way bigger than just me. Obviously, I'm the founder and all that kind of stuff, which is great. But we're bringing in new team members, amazing mentors. It's not just a one-man show, and I want to support the other people who have contributed so much to HRT University. So anyways, I thought it'd be more appropriate to call it the HRT University podcast, because that's really what it is, brought to you by the one and only Nico Misleh, right? So I'm going to silence my phone here real quick. We're going to get started. I wanted to answer a question. I see this one come up over and over and over and over and over again. It's cited in the master course, and probably not in enough detail. So it's something I actually want to kind of consider maybe adding a little bit more detail around. But I have actually written a daily email about this subject. And it's basically along the lines of, can we start hormone replacement therapy in women, especially 10 years post-menopause, right? Which a lot of times you might even see that as like greater than 60 years old. I don't know if they're necessarily one and the same in my opinion, but the consensus is essentially, once you're older than 60 or once you've been at least 10 years post-menopause, there is this risk that increases as you get older, 10 years post-menopause, around hormone replacement therapy. And it's usually around cardiovascular events, strokes, clots, and things of that nature. So I want to answer this question. So again, the question might be something along the lines of, like, I have a 72-year-old lady and she's asking for HRT, and I was told to never, ever, ever start HRT, after a female 60 years old or whatever, 10 years post-menopause. What the heck do I do? Right? So this question, I get it, because it's kind of stemming from this cognitive bias, this discomfort, and again, lack of confidence around what are we supposed to do. We've been told this stuff, and look, it has been cited in the literature in the past. So it's not like it's a made up thing, but I want to kind of describe to you where this all came from. Okay. So, it's clear to me, at least, that a lot of this started during the what we call WHI era, or Women's Health Initiative era, right? Which was that big study that was done, nearly 2 decades ago now, around women and utilizing specifically non-bioidentical hormones, right? So that would be conjugated equine estrogen and progestin. Okay. So that's where these concerns stemmed around, because again, what they discovered through that WHI trial was that there was a slight increased risk of cardiovascular disease, stroke, what we would call venous thromboembolism, aka clots, dementia, breast cancer, like all these little things kind of came up. Now, again, apparently we've gone through the literature and said, hey, some of this WHI data, maybe it was kind of flawed, and we redid the numbers and the risk is actually a little bit lower. That's fine. That's fine. It still stands to reason that there is a little bit of that risk. And I would argue that most medical providers, conventionally speaking, utilizing hormone replacement therapy, especially kind of on the more synthetic side, using conjugated equine estrogen or progestins, for example, they would still cite that it is not a good idea to utilize, especially these types of medications in women 10 years post-menopause, because it's going to increase the risk of clots and all these different things, right? But again, you guys know this. And if you don't know this, I want to teach you this. We are not talking about Franken hormones here when it comes to bioidentical hormone replacement therapy, okay? I've talked about this in many different episodes, but when I say hormone replacement therapy, I mean hormones, like the real things that are floating around in our bodies, okay? I'm not talking about these Franken chemicals that we created in some godforsaken lab called conjugated equine estrogen and progestins, okay? Like medroxyprogesterone acetate, or MPA. That's not what I'm talking about here. Those are the medications that we did see those risks come up and around, and we still to this day see some risks around those. Um, so I want to again get at this because when they kind of re-reviewed or re-examined some of those WHI trial findings with a little more nuance, it was a study done in 2024. It was by Taylor and Davis. This review, they kind of, again, reassessed cardiovascular, thrombotic events, dementia risk. And that review did demonstrate that there was some timing and formulation and patient selection that really mattered. Okay, so it's very nuanced, again, even coming from the conventional side of things. So even within conventional CEE and progestin data, the risks were often overstated. Okay, so again, the WHI trial does not inherently support or the findings therefrom a blanket ban on HRT after 60, even from the conventional side. So I'm giving the devil its due here, okay, folks? They're not saying that it is a never, ever total 100% contraindication, ever. But I want to now take your attention to kind of an HRT University theme. Taking a sip of delicious coffee here, I want to take you to what we teach in HRT University, okay? Kind of the principles behind that. Number one, we are utilizing bioidentical hormones, which I like to just call hormones, okay? BHRT is fine, but I like to call it HRT because that's what it is. It's hormones. It's not some fake gobbledygook that we came up with in a lab. When we move away from the conjugated equine estrogen, from the medroxyprogesterone acetate, we actually see outcomes improve even further and risk even lower. Okay, so I'm not saying that the risks were overstated or were totally overstated when it comes to the WHI stuff. What I'm actually saying here is that we still find greater benefit and overall outcomes with the bioidentical hormones. So specifically, estradiol and progesterone. So let's take the Replenish trials. Okay, this was a trial done utilizing oral. I want to cite that first, okay? Because a lot of you folks out there, if you're not familiar with HRT, again, oral estradiol is like the devil incarnate. It's got all these problems. It's going to cause all kinds of issues, especially things like clots. Never, ever, ever use it. It's not true. It's just not true, okay? The Replenish trial, they gave women estradiol and progesterone orally, and it included women up to 65 years old. Okay, so they did not exclude what you would kind of assume to be that female who's above 60 years old. So it included women who are likely 10 years post-menopause, okay? And what were the findings? What they found was that there was no clinically significant adverse effects on metabolic markers, coagulation parameters, big one, ding, ding, ding. No issues with coagulation, even with oral estradiol. They didn't find any issues with cardiovascular risk. The endometrial hyperplasia rates were like less than 0.36%, which is basically none. They found no increase in breast cancer. Okay. There was no abnormal mammograms over 12 months. What about the big ones, right? What about clot and cardiovascular risk? Okay, if we compared estradiol and progesterone bioidenticals versus CEE and MPA, it was actually a 30% lower risk of clots with estradiol and progesterone. And again, there's a mechanistic explanation behind this. This isn't just like magic. So estradiol, remember, it has a more favorable hepatic and coagulation profile. It just does in and of itself. Progesterone doesn't carry the same risk at all as progestins. We know that to be true. Of all the, CE versus progestin tends to stand out as the one that's going to cause more problems. Okay. So we can move forward from this. Let's look at, there was a longer term study done. They were using topical bioidentical hormones, but nonetheless, this was by Potello et al. 2014. It was a 5-year observational data study design. And the women were aged approximately 60 to 70 years old. Okay. So we have women who are way past, 10 years post-menopause. And they used topical formulations, estradiol and progesterone, and they also used estradiol, estriol, and progesterone. Again, all bioidentical hormones. What did they find? What were the outcomes? Improved bone density, improved, when it was all in physiological ranges, they found that improved mineral density and bone density. There was no increased risk in cardiovascular events, breast pathology, breast cancer. And again, that's really freaking important because this reflects that real world, longer term use is not limited to short trials or even younger populations. There are actually studies, which I just cited, that are looking at women beyond that 10 years post-menopause. And so again, what is the data supporting here, folks? What are we getting at? HRT is totally safe and effective in women over 60 years old or 10 years post-menopause, period. Age alone is not a contraindication, nor is that 10-year time frame. Okay, the risk is literally driven by the type of medicine, right? Is it bioidentical or not? I guess we could kind of consider route of administration, although we didn't really see much there in terms of oral to topical. Individual cardiometabolic profiles. Like, is this patient super duper sick or not? Like, of course that could play into this. How much time have they gone since they were deprived of estrogen, right? 10 years post-menopause. But what we're finding still, guys, is that earlier initiation is always better. I mean, we can pretty much make great certainty around that. The earlier you start HRT, the better. And that's what we teach in HRT University. Like, please don't wait for these ladies. I mean, HRT has no age, right? It should be utilized when medically necessary, whether the woman's 20 years old or 50 years old or 70 or 80 or 90. I have patients that are in their 80s and 90s. I literally do. And I've started them on hormone replacement therapy and they are all the better for it. But my gosh, it would have been a whole lot better if I could have started them at 30 or 40. Right? So again, later initiation, it's not forbidden. It's not a contraindication, especially when symptoms and quality of life are really super significant, right? So, think about this. Most women in their 60s and 70s and beyond are a little sarcopenic, are usually a little bit osteoporotic. They have cognitive decline. They're living a lot of times in some amount of pain, chronic pain. They're dealing with terrible vaginal dryness, oftentimes recurrent UTIs and things of that nature. So really withholding HRT based purely on age or that 10-year post-menopause thing is probably definitely going to increase morbidity and mortality. It's going to reduce their functional independence. It's going to totally accelerate that decline. That's all that this is. So again, what I like to tell providers, and I know this is a very political answer here, but this is about shared decision making. Okay? Every patient deserves a discussion of risk and benefits, risk versus benefits, an individualized plan, and a provider like you and I who actually understand the data. Honestly, we've kind of gotten rid of that outdated dogma crap. And now we get to empower our patients with actual informed consent. Okay, so you can use this podcast and the data I presented here to go back to those patients and say, hey, it's totally okay, it's safe. You're not wrong. I didn't know, right? I didn't know that this is the reality and this is totally safe. So I always like to say this, like, HRT doesn't discriminate by age. Okay, there is no age for when HRT is safe or effective. All right, it's when it's medically necessary. Prescribing later in life for women 10 years post-menopause is not prohibited. Okay, the fear around medicine and the cognitive biases that we hold, it's not improving anything. It's not helping. Okay, and I want you guys to be movers and shakers. You know what I mean? Like we're in a movement together to make this better for all of our patients. Like, that is the truth. So I want to present evidence to you to show you again, because what's that famous quote? It's like, God is the truth, for everybody else, show me the data, right? I can't just sit here and say, well, it's totally safe. Why? Because I say so. Like, that's not that helpful. So I hope that I've given you enough evidence, and I think it's plenty, to say, hey, I get it. I understand it. And now I can move forward. And by the way, this is what we do inside HRT University. Okay. Like, I want to provide you with evidence because that's important. And I also want to give you the confidence, right? If I can imbue, if I could give that to you some way and be that guide for you, let me do that. Let me help. My whole team at HRT University, that's what we're driven by, is how can we get providers to not just like memorize all these things, but like really truly know it and understand it, right? Because once you can comprehend this stuff, once you have again, the knowledge and the wisdom behind this stuff, all of a sudden the confidence just goes through the roof. And that's what I want to provide you. Like, I want to provide you the reason why. Why do we give hormones in the first place? Why is it that we can give hormones from to any woman at any age, realistically speaking? Like, those are the things that I want you asking yourself. And I want you to know that if it's like a struggle bus for you and it's hurting your heart and soul and you feel lost and you feel like you go over here and this person says that, and then you ask your friend over here and they're saying no, and then you look up online and find some crazy YouTube video, whatever it is, I want you to know at HRT University, I'm going to present it to you. I'm going to present it to you, I think, in the fairest light possible, the evidence, the data, and also the depth that is necessary to really gain that confidence so that you can go out in the world and treat these patients who are desperately seeking hormone replacement therapy, because they are. Like, do not refer those patients out. They're your patients. Okay. You can make a great living doing this and put your head down on your pillow every night in peace because you know that you're actually doing things that improve their life and decrease all the risks. Okay. So I hope that's helpful, folks. I'll end it there. Thank you again for joining me, and get out there and go treat patients with good old fashioned HRT. Love y'all. Thanks.